Okay, let's do this again. Hello, everyone, and welcome to today's Rafael Medina subspecialty VMR. My name is Elena, and I'm super excited for today's session. The topic we'll be discussing today is going to be pulmonary and critical care. And as such, we have two fantastic educators today. But before I let them introduce themselves, I would like to thank our two CPS Academy members, Parisa and Ethan, who are going to be scribing and doing the teaching points today. All right, so let me introduce our discussant, Dr. Leonid Mirson. Leon is a pulmonary and critical care fellow at the University of Pennsylvania. He received his medical degree from the University of Pittsburgh and completed internal medicine residency at the Johns Hopkins Hospital Osler Medical Residency. Leon, why don't you share with the crowd why everybody should go into pulmonology, and maybe you could also share something that you enjoy outside of medicine and PCCM.
Certainly. So I went into PCCM for a few reasons, but I think my favorite part of pulmonary and critical care is that it's such a systemic field, in the sense that so many diseases that affect the lungs, and especially in critical illness, affect so many other organs in the body. And we all went into internal medicine for a reason. And the idea of isolating yourselves to one organ system without thinking of the others was never very appealing to me. So I like the systematic approach and the systemic pathologies that often affect the lungs, and it keeps me feeling like I'm an internal medicine doctor, which is really enjoyable. Outside of medicine, I really enjoy trying all the different restaurants in Philadelphia, and my fiance is in New York right now, so I'm constantly commuting back and forth. So eating out all the time is mostly the hobby I've been enjoying for the last year or so.
That sounds awesome, Leon. Is there any particular food that you enjoy in particular?
Oh man, I'm really not picky about cuisine. I like trying all sorts of different types of foods. We went to a delicious Thai restaurant yesterday, so that was wonderful.
That sounds really great. I have done a couple of internships last year, and I haven't been in touch too much with pulmonology, but I have had a very similar feeling, I think. I really love pulmonology and as well for its broadness and also the part of the critical care. So yeah, super excited for your discussion.
Thanks for having me.
Um, On the case presenter seat, we have our very own Dr. Vijay Balaji. Vijay wants me to call him just Vijay, but I'm going to say his full name once. He's also a fellow in PCCM and currently works at the All India Institute of Medical Sciences, Rajasthan, India. Vijay, why don't you share with us what you enjoy about PCCM and maybe what drives you outside of medicine?
Hello everyone. So the only reason why PCCM was very interesting was the diversity that it gives us. So I think all of us somewhere, although we end up subspecializing, uh, internal medicine stays at the core of all of our hearts. So the diversity that PCCM gives in of some procedures, critical care, outpatients and inpatients. So, and you are helping someone in the last moments, life and death. So I think that somehow drives me into PCCM. Apart from outside of medicine, I love cooking. So I've been recently trying dishes. Apart from that, I also love playing table tennis. It's a new hobby that I've caught up on. So,
That sounds really great. So we don't have only two people who enjoy PCCM, but also food, which is great. And yeah, for those who don't know, Vijay personally, he is the one person that always teaches the whole academy about ECGs and CTs of the chest and honestly, whenever I have a question about an ECG, I would approach VJ first, and I would also I would always get a fantastic teaching. So that's been super great. All right, Ethan jumped in last minute to do the teaching point, so thank you again for doing that. And Parisa, I think I made you co-host, so whenever you're ready, you can bring up the board, and VJ, you can share the first aliquot with us.
So this is a case of a 38-year-old gentleman presenting with worsening dyspnea for the past 3 months. Coming to the HPI, the patient has noticed shortness of breath for the past 2 years. He initially was breathless on walking about 2 flights of stairs. It has been progressively increasing, and since the past 1 month, it has worsened that he is breathless on just walking about 100 meters or just doing some minimal exertional activity. So apart from this, the patient denies any paroxysmal nocturnal dyspnea or orthopnea. He denies any fevers, syncope, hemoptysis, or chest pain. Review of systems is negative for any weight loss or any other system involvement at this point of time when I saw the patient.
All right, VJ, thank you so much for the first aliquot. Leo, now that you're a fellow, you shared with me before the session that you have been here presenting a case as a medical student. How do you think now about a patient who presents with dyspnea? And what I'm hearing is that this is kind of a chronically progressive process. So how do you teach young learners how you think about this chief complaint?
Perfect. So even in this limited amount of information that we have, there's already a ton to dive into. And I like to separate dyspnea into, as you've already called it, chronic, and that's correct, acute, subacute, or chronic, because partially that will change how important it is to manage right away, meaning an acute onset cause of dyspnea is much more likely to be a more severe, immediately needs to be treated cause, whereas a chronic process gives you a little bit more time to think about things. So that's the first step, is how acute is the presentation. Then to take dyspnea apart, it's important to think about, is this dyspnea on exertion? Is this dyspnea at rest? And how much of each is at play? Because that will give you a hint to what could be going on. It's important to remember that dyspnea is not always solely due to a pulmonary process alone. It's really important to consider other organs that may be at play. With this history that's given to us, before I even get to the pulmonary manifestations, I'm always thinking, could this be a cardiac cause, whether it's coronary artery disease and angina, or could this be a valvular disease? That's something that's in the back of my mind, something that's progressive like this. Then when I jump into what kind of pulmonary process could be going on, I usually break the differential down in a couple different ways. The big 4 buckets of pulmonary are parenchymal processes, airway processes, vascular processes, or pleural processes. There's not much here going for a pleural process. Certainly could have a long-standing chronic pleural effusion, but the history isn't giving too much of that, though we'll learn more. Airways, something like asthma or COPD, does not really fit with this kind of presentation, but something we'll need to consider and we'll get more information about. Vascular disease certainly could be at play. Pulmonary hypertension can present as chronic or subacute onset. Dyspnea, particularly with exertion, that's progressive. So that's something that's in the back of my mind. And then a primary parenchymal process, some sort of interstitial lung disease, chronic infectious process, or an organizing process could be at play as well. So I'm sure we'll learn more that will help us kind of break this down a little further.
Yeah, thank you so much, Leon. I was wondering if the age is something that helps you in this situation or not.
I think age absolutely is very helpful in this situation. So if this were an 80-year-old male with a significant tobacco use disorder, yes, COPD would be up there, but so would processes like IPF, other interstitial lung diseases that are more common in that age group would be much higher in my differential. A more fibrotic process in a 38-year-old would be unusual, and I wouldn't expect to see severe COPD manifest in this age group, though certainly it can. Same thing with cardiovascular disease. You wouldn't typically think of ischemic heart disease in a gentleman this young, but still in the differential. So I think age is very, very important here.
Yeah, thank you so much, Leon. And one last question before I pass the mic back to VJ. I think for me as an early learner, I'm asking myself in any kind of chronic process, but now we're seeing dyspnea. What is it that keeps patients waiting, or what is it that keeps patients presenting at a certain point? What in your experience is it that tips them over or makes them present to us?
Yeah, and that's a very important question to ask them too. Sometimes I think it's different things for different people. So young males, for instance, tend to wait a little bit longer before presenting. And I mean, I'm guessing for this person that starting to develop dyspnea at rest or with minimal exertion in the last 3 months might be the thing that tipped him over. But it's important to identify what has changed, what specifically has changed, as you suggested. And that might give you a clue to a more acute on subacute or acute on chronic cause of dyspnea.
Awesome. Thank you so much. VJ, why don't you give us the next aliquot?
Yeah, sure. So apart from this, we did not have any other strong clues for the cause of dyspnea. Coming to the past medical history, about 10 years ago, the patient had upper GI bleed, at the point of which he was diagnosed as cryptogenic cirrhosis, with an evidence at that point being a shrunken liver, dilated portal vein, and splenomegaly on ultrasound. Since then, he has been on beta-blocker prophylaxis with propranolol, and since then, there has been no decompensations. Coming to the exposures, family history and social history have been not significant. He does not have any addictions or allergies, and he's currently monogamous and has 2 children. Coming to the exam, the pulse, the temperature is 98 Fahrenheit. BP was 90/60 mm of mercury. The respiratory rate was 22. The heart rate was 78. The saturation was 93% on Romer. The general physical examination, there is no clubbing. And systemic examination showed fine end inspiratory crackles in the lung bases. Other systems were unremarkable. Coming to the basic labs, the white blood count was 3,740, with neutrophils being 60% and lymphocyte of 23%. Hemoglobin was 10, baseline hemoglobin of 9.6 with an MCV of 98. The platelet was 56,000. And the peripheral smears showed normocytic normochromic picture with ovalocytes. There was no atypical cells or blasts that were noted, or schistocytes. Coming to the liver chemistries, the bilirubin was 0.9. The AST, ALT, and alk phos were normal. The AST was 32. The ALT was 56. And the alk phos was 141. Bilirubin was 0.9. The INR was 1.41. And the APTT was 41. The lab cutoff was 28. The urea was 18, creatinine of 0.96. And HIV, HBsAg, and anti-HCV were negative. At this point, screening ECG showed a normal sinus rhythm with no acute changes.
Yeah, fantastic. Second aliquot, Vijay. Super, super interesting. Maybe before we jump into the physical exam and the labs, I'd be curious, Leon, from your pulmonary and critical care perspective, how do you think about patients who have cirrhosis and portal hypertension in that context, especially in a patient with such a young age?
Yeah, so the history of decompensated cirrhosis and portal hypertension certainly um, is very important in this particular patient. Um, there's a finite number of pathologies that it can affect both the liver and the lungs, and specifically liver affecting lungs as well. With this type of history, things that I'm starting to think about now that I wouldn't have thought about otherwise would be things like portopulmonary hypertension that can cause worsening chronic dyspnea. We talked about vascular disease. We can think about the hepatopulmonary syndrome, a form of shunting that can lead to dyspnea and hypoxia. And there's some physical exam maneuvers and other imaging findings that might be more supportive of this. We can think of causes of cirrhosis that also affect the lungs. So things like short telomere syndrome leading to lung fibrosis, leading to cirrhosis are possible. We had mentioned COPD earlier, one of the most, or not one common, one of the causes of COPD and liver disease could be alpha-1 antitrypsin deficiency. We need it doesn't sound like there's any tobacco use history for this patient, which typically is somewhat present in patients with COPD and alpha-1, but certainly doesn't rule it out. Those are some of the probably most common joint pathologies we see, and I think all of those are on the differential. When I apply that to this patient, any of those could be at play. What's interesting is the fine respiratory crackles that you heard on physical exam. I wouldn't expect pulmonary hypertension, portopulmonary hypertension to result in crackles. That's a more parenchymal process, whether due to pulmonary edema or due to some degree of fibrosis. Same with hepatopulmonary syndrome. It would be unusual to see that as a physical exam findings, that we all know that crackles on a lung exam are not sensitive nor specific. So those two fall a little bit down until we get some more imaging and maybe PFT information and some other studies. Alpha-1 is certainly a possibility, as is telomere disorder leading to fibrotic lung disease. And the absence of clubbing doesn't point me one way or the other. What I'll just point out that is interesting, for a patient who's had long-standing cirrhosis, normal bilirubin is a little unusual. Could I just clarify, is the INR 15 correct, or is it 1.5?
1.5.
1.5, okay. So maybe some degree of synthetic dysfunction as well. It seems that the diagnosed cirrhosis is well established and has had decompensation. I just think that's interesting and not something we typically see. And the cytopenias don't help me too much one way or the other, because you could certainly see them in cirrhosis. But as we get more studies, we'll have to think more carefully about whether that could also be contributing to pulmonary pathology. Again, with short telomere syndrome, you can have bone marrow dysfunction as well. So there's something in the back of my mind.
Thanks, Leon. I particularly enjoyed how you mentioned that how cirrhosis can lead to certain pulmonary pathologies, but also how certain syndromes can affect both the liver and the lungs. I think for me, yeah, as an early learner, I would sort of be concerned for the vitals in this patient, especially the blood pressure. Is there any advice that you can give me and everybody else here, how you would deal with such a patient? I believe that the saturation is still in the normal range. But how do you think about that?
Yeah, and I would probably I'd start with the blood pressure, and so that blood pressure of 90/60 in an otherwise healthy 38-year-old male would be quite concerning for some more acute process, either hypovolemia or some sort of unusual shock state. What I would do is I would look back to see that patient's previous blood pressures, because with a history of cirrhosis, I would not be surprised if this is the baseline blood pressure. So that would be my first step. If it is baseline, then that's reassuring. And the chronicity of this presentation is also sort of reassuring that there might not be something going on today. Though, as you yourself pointed out, why did this patient choose to present today is always a question. Now, the saturation of 93% at rest is very telling, that there's certainly some degree of hypoxia going on. While it's safe at rest, I think it would be really helpful to get ambulatory saturations on this patient, whether they're in clinic or even in the emergency room. Walk them around, see how much that oxygen level drops. Because with this history and what we're starting to gather, I suspect they will be hypoxemic with exertion. An arterial blood gas may be helpful, but it's probably not necessary specifically at this point, though I'm sure we'll get to it.
Thanks, Leon. Would you mind explaining why some diseases particularly induce hypoxia when you exert them? Does it help you like narrow down to certain diagnoses? Do all kind of pulmonary processes can cause exertionally induced hypoxia?
So some diseases are much more likely to cause exertional hypoxemia than others. Particularly disease states in which you need to maximize the amount of time that the blood spends in the alveolar capillary bed, are particularly prone to that. So what I mean, for instance, a patient with pulmonary fibrosis who has a diffusion barrier, when their heart rate goes up or their cardiac output goes up for whatever reason, the blood shoots through their pulmonary capillaries much faster than at rest. And because they have already a barrier to diffusion, that doesn't give them enough time to oxygenate the blood. So as an example, a patient with interstitial lung disease, at least in the early stages, tends to be okay at rest. And then any degree of exertion where their cardiac output goes up causes a precipitous drop in saturation. Patients with pulmonary vascular disease, you see very similarly the amount of time that the blood needs to spend in that pulmonary capillary beds is so important. So those two disease states and anything affecting that barrier, that interstitial alveolar capillary barrier, so that can include pulmonary edema, that can include organizing pneumonia, or pneumonias of any kind, would all affect that. Now, other pulmonary disease states like COPD and emphysema will also be affected to a degree, but it's usually not as precipitous as you see in these kinds of states. So what I suspect is this patient will desaturate quite rapidly with exertion, and that will probably point us to one of these other pathologies.
Awesome. Thank you so much, Leon. Maybe one last question before I pass the mic back to Vijay for the third aliquot. You have mentioned that cirrhosis can cause a variety of pulmonary diseases. And you mentioned hepatopulmonary syndrome and also portopulmonary hypertension. Maybe you could give us just a quick 1 to 2 sentence idea of what those diseases are. And I think you also mentioned that there are certain tests that we could do clinically, but also maybe with the saturation and how and why you wouldn't expect the crackles as you mentioned.
Yes. So these are the terminology behind the diseases is like very confusing and confused many generations of med students, residents, fellows, and attendings. Hepatopulmonary syndrome is a disorder in which you have abnormal shunting in the lungs. The etiology is still being debated, but something in cirrhosis causes abnormal development of basically pulmonary AVMs, where blood shunts from the arterial side to the venous side without really going through the capillary bed, leading to hypoxemia. There are certain characteristics that you can look for. So the presence of something called platypnea and orthodeoxia is a major characteristic, a major finding. Echocardiogram with a bubble study will often show intrapulmonary shunting, and a CT angiography study will show the presence of AVMs. Those are all diagnostic elements of the diagnosis of hepatopulmonary syndrome. Portopulmonary hypertension is a form of pulmonary vascular disease. I believe it's a group 1 pulmonary hypertension disorder that the etiology of which is also poorly understood, at least last I read about it. But the presence of chronic portal hypertension leads to pulmonary hypertension and all the subsequent issues that involves. The diagnostic workup of that would probably be starting with an echocardiogram, looking for evidence of RV dysfunction, looking for evidence of elevated pulmonary arterial pressure, and ultimately you'll need a right heart catheterization as well as a catheterization of the portal system to look at the pressures and seeing how much is contributing.
Thanks so much, Leon. I think I'm always impressed by how cirrhosis is such a systemic disease. And Leon, would you mind sharing with the information that we have about this patient so far, what are the next steps that you would do for this patient? And then Vijay, you can take over and share what you and your team did.
Wonderful. So I guess I can sometimes it's helpful to just summarize a problem representation for this patient. So I would say this is a 38-year-old male with chronic onset but progressive dyspnea on exertion, now progressing to dyspnea at rest, with a history of cryptogenic long-standing cirrhosis, who's found to be borderline hypoxic on room air with physical exam evidence of crackles, pancytopenia, and mildly elevated liver testing. So I would start, there's a few things we would do. I'd really love to do a ambulatory saturation. I want to know how much this patient is desaturating, because that's going to guide the differential a little bit and is also going to guide our management. A chest x-ray, I'm sure we will get. I think more likely than not, we're going to progress to a chest CT, but x-ray is always an excellent first step, and it'll help give us an idea of what's going on. This patient will almost certainly get an echocardiogram, and I'd like to do one with a bubble study as well. And from that point on, we'll have enough information, I think, to guide our differential diagnosis and further testing.
Awesome. Vijay, what did you and your team did?
Amazing. So these were something similar that we had. So on examination, we noted that the patient on walking about 200 meters, saturation went up to 70% on room air, which improved at rest of about 1 minute. So I'll give you the, I'll just share my screen for the CT. Is my screen visible?
Not yet. Now we can see it, yes.
Okay, great. So I'll just a moment.
Maybe we can
Keep
maybe we can keep that image up for a second, and Leon, you can just share your impressions and how you think about or how you approach CTs of the chest. I think Leon, I think we can't hear you. I think you're muted.
Sorry.
No worries.
Forgot how Zoom works. So there's 100 different ways to approach CTs, and I'm still trying to refine my own systematic approach. I like to start by looking at the airways and the vasculature first, and then going to the parenchyma, mostly as a reminder to myself to do it, because nobody's going to forget to read the lung portion of the chest CT, but it's very easy to ignore the other stuff, and radiologists are very good about this. They do this very systematically. Using the airways as my guide, I see, is this an inspiratory and expiratory film? Because that's going to matter later when I'm trying to interpret air trapping or mosaic and attenuation. I'm certainly not a master of reading pulmonary vasculature. But I like to know, is this a contrasted study? Is this not? If it is a contrasted study, is it correctly timed to look for a PE? If there is one, is there any reflux of contrast? Where is the PE located? That kind of things are all very important. Then I turn my attention to the lung windows. And certainly, I'm sorry, PJ, this is a is this a non-contrasted CT, it looks like? Is that right? Yeah. So then I turn my attention to the lung windows, and I do a quick scroll through once from top to bottom. What is the most glaring thing that's jumping out at me? And I get that as my sense. Then I do a much slower lobe by lobe evaluation, and I look for, if there are infiltrates, are they central or peripheral? Are they upper or lower predominant? And are they symmetric? And then I kind of piece everything together. So there's a lot, and in this particular CT, there's a lot to unpack, and I'm happy to do it, but that's my systematic approach to this.
Yeah, thank you. Thank you so much, Leon. Vijay, do you think this is a good point to just go through the images and let Leon share what he thinks?
Yeah,
And
I'll
then,
just give all the detail that I think we can have a better discussion.
of course.
Yeah, so the read was there is evidence of traction bronchiectasis and broncholectasis with areas of honeycombing and patchy GGOs, suggestive of a fibrotic NSIP. Coming to the CT abdomen, it showed multiple portosystemic collaterals with irregular nodular shrunken liver with fatty replacement of lower paraspinal muscle suggestive of a myopathy. Based on this CT findings, we went ahead to see what would be the etiology of the findings that we had. So we got an RA factor, anti-CCP, ANA, ENA, ANCA were negative. The anti-smooth muscle antibodies, the LKM, the anti-TTG antibodies, and ceruloplasmin levels were negative. And we also did a transthoracic echo and simultaneously did a contrast bubble. So it showed evidence of a shunt that came after the sixth cycle. During the sixth cycle, there was a shunt that was noted. And the pulmonary artery systolic pressure was 34 millimeters of mercury.
Thank you, Vijay. I think there's a lot of new information that we can digest together. Leon, maybe you can comment on the CT chest first, and then I would like you to talk about the bubble echo. And maybe you can explain to us in a way that you would explain to somebody who has never heard about the bubble echo and how it's performed and what it tells us. Yeah.
So the bubble echo, it's nothing fancy. All it is basically, you can even do, if you're a fan of POCUS, you can actually do this yourself. It's very simple. All you do is you take 2 syringes of saline with a stopcock, and you just agitate them back and forth, basically creating little micro bubbles, and you inject them through an IV while taking a look at the 4 chambers of the heart in whatever view you prefer. It is normal to see a ton of bubbles in the right side of the circulation, right? That's where you're injecting it into, and that's where you would expect to see it. If you start to see bubbles cross over to the left side of the heart, that speaks to some degree of shunt. If you see bubbles crossing really early within the first, I believe it's the first 3 or 4 cardiac cycles, we say, that's evidence of a intracardiac shunt. So you're invoking some sort of hole between, some sort of shunt between the right and left side directly in the heart. If it's delayed passage of contrast, such as in our patient study, that invokes intrapulmonary shunting, or shunting that's taking place in the lungs, and tends to speak to some sort of AVM type process that's there. The degree of how many bubbles you see can be graded itself, grade 1, grade 2, or grade 3, with grade 3 being basically like innumerable amount of bubbles present in the left side, grade 1 being like, I don't remember, I always have to look this up. It's like something under 10 bubbles, not very impressive, speaks to the degree of shunting that you see, the severity. The presence of shunt in this patient is probably suggestive of portal pulmonary syndrome, though not diagnostic in and of itself. You also need to have visualized anatomic abnormalities, and presence of desaturation. We have many of those, and I think it's a safe diagnosis, but maybe not even the predominant diagnosis in this patient, because there's something else going on in the chest CT that we see. That's my interpretation of the echo portion. For the CT itself, I mean, it's a very impressive chest CT. There's a ton of parenchymal fibrosis going on. The big fibrotic changes that we saw are the honeycombing at the lung bases, the traction bronchiectasis, and the irregular reticulations that are actually present top to bottom throughout, very peripheral predominant. I think NSIP is a reasonable kind of putting it together. There's some ground glass, there's some consolidation. It's not purely an UIP type process. But it's certainly, I think that is the predominant cause of our patients' hypoxemia and progressive dyspnea and desaturation, probably much more so than the probable hepatopulmonary syndrome the patient has.
Awesome. Thank you so much. I would be curious, is the CT that we got from VJ something that you expected in this patient, or is it surprising you?
Sorry, was that addressed to me or VJ?
No, that was addressed to you, Leon.
Can you repeat the question? I
Yeah,
apologize.
sure. No, I was curious if because of such extensive pathology that we have seen on the CT of the chest, I was just curious with the history that we've gotten so far from the patient, is that something that you expected or were you surprised?
I mean, I think I was surprised by the severity of
Hmm.
the parenchymal changes. I will say when we did that walk test and we saw the patient desaturate by nearly 23% with ambulation alone,
Hmm.
the possibilities for why that might be are very few. It's either severe parenchymal lung disease or severe pulmonary vascular disease. With the PASP of basically normal, that's largely, and no evidence of RV dysfunction. It doesn't rule out significant pulmonary vascular disease, but it sort of makes it much less likely. So that chest CT would certainly explain the degree of exertional hypoxemia that we see. I would have sent off all the serologies that VJ's team sent off, I think, because when you see something like NSIP or any kind of fibrotic lung disease, you want to make sure, and you want to get more rheumatologic history. You want to make sure that this is not a connective tissue disease related process. Not hearing much, my biggest concern is that this might be a telomere based, a short telomere syndrome leading to pulmonary fibrosis and cirrhosis. And now the question is his bone marrow, is his CBC findings related to the cirrhosis more, or the short telomere? But I would send off the short telomere testing after those antibody tests came back negative.
Awesome. Thank you so much, Leon. I think we're at the stage where the case gets certainly very difficult if you're not into pulmonology. So what I would like to ask you, which is something that is super confusing to me, and I have to look it up every time, is the HRCT patterns that we see in interstitial lung disease. You've mentioned UIP, you've mentioned NSIP. Is there any way you teach your residents how to think about those different patterns and what clues they might give you into thinking of different syndromes? Yeah.
That I think the first thing I teach residents about when we talk about different patterns of diffuse parenchymal lung disease is the importance of, can you successfully identify UIP or not UIP? Because it turns out UIP has a very limited differential diagnosis. UIP is characterized by typically basilar, predominant, peripheral, fibrotic changes, and it can be graded in, is it probable UIP, is it possible UIP, etc. And a lot of times, if you can decide that this is definite UIP or probable UIP, depending on the patient's history, you may obviate the need for any form of biopsy and make your diagnosis right there. UIP is often incorrectly used interchangeably with IPF because something like 75% of patients with UIP have IPF, but not always, right? And so it's really important to not finish your diagnostic process that this is UIP, therefore the patient has IPF. You want to make sure that they don't have autoimmune diseases, connective tissue diseases, or other diseases that might lead to a UIP pattern. So your diagnostic process is not done at that point. However, if you've ruled out connective tissue diseases, you've presented this patient at a multidisciplinary conference, and there's nothing that's positive, you can confidently make the diagnosis that this is IPF without any need for tissue biopsy. So that's why we talked about UIP so much, because it's such an important diagnostic point for patients. NSIP is different, has different characteristics on chest CT. There's more ground glass, there's more consolidative type changes than you would see with UIP alone. Otherwise, it can look very similar sometimes to UIP, and sometimes we argue a lot about whether this is UIP or NSIP. Historically, NSIP we think of it as more having to do with connective tissue diseases, but sometimes it's idiopathic as well. It can be fibrotic, just like it is in this patient. So everything that Vijay's team sent looking for connective tissue disorders is exactly the correct thing to do. But that's generally where I start, and it's a confusing concept, and looking through many CTs is probably the best way to learn about it. But one takeaway is UIP or not UIP is going to be extremely helpful in your diagnostic pathway.
Yeah, I think that was tremendously helpful as like an introduction to how we approach those kind of patterns that we might see, and it certainly takes a lot of practice. Yeah, I think before we pass the mic to Vijay for the last aliquot, I was wondering how those findings that we just got from Vijay are changing your problem representation of the patient, if they help you narrow down some of the differentials that you have already mentioned. And in particular, you've been mentioning short telomere syndrome, and maybe you can give us an idea of what that disease is and how it affects both the liver and the lungs.
Yeah, so short telomere syndrome is a relatively recent syndrome that's been discovered probably in the last, I think, couple of decades, if that we found is a genetic, it is a genetic disorder, typically, that presents with a wide variety of manifestations. But included in those are bone marrow dysfunction, pulmonary fibrotic changes, and cirrhosis. One of the elements of short telomere disorder is usually strong family history of dysfunction of one of those three. There is some degree of anticipation, meaning that each subsequent generation tends to develop fibrosis or cirrhosis a little bit earlier than the previous one. So for this gentleman, I'd really like to get a family history of lung disease, liver disease, bone marrow issues. Early graying is often a sign that we associate with short telomere syndrome. And depending on the positive or negative responses that he gives us, that might clue us into this is probably what's going on. But I wouldn't anchor on it. There's still other workup that needs to come back. And it's important to think about other etiologies of this diffuse fibrotic pattern that we see, including connective tissue diseases we've been describing. I think the bubble study is interesting, and I would certainly probably get a CT. I would consider at least getting a CT angio to look for the presence of AVMs, and I would try to quantify how much desaturation is occurring at rest or sitting up. But I think it's maybe less important to this patient's presentation at this point in time. And a lot of times we need to continue expanding our differential if things aren't fitting. So though I hypothesize this is going to be a short telomere case, depending on what other information we have, we may need to pivot to alternative processes.
Yeah, I think it's absolutely fascinating how you digest all of this information, and certainly very inspiring. Vijay, I believe that you have one last aliquot before you reveal the diagnosis, and I think I'm gonna ask Leon before the diagnosis to like narrow down some of the differentials that you would be thinking about, and how you would rule some of them out and rule some of them in. Let's go ahead, Vijay.
Amazing thought. So I just got a EBG in the sitting and supine that was suggestive for orthodeoxia with no improvement in supplemental oxygen, and the A gradient was more than 15. So with this syndrome, when I just saw the patient and when he was admitted, so he just looked completely normal. So retrospectively, when we asked him if there's any graying of hair, so he just said, he's been using, hair dye for about 5 to 10 years now. So apart from, so this is we sent a telomere testing. It is due, so it takes about 3 months to get a telomere test done in our country. So we also feel, and the bone marrow testing, so the patient denied to get a bone marrow testing done, although we explained the possibilities. So we could not get a bone marrow done for this patient. So I think we likely concluded that this patient had mostly a short telomere syndrome. And somehow transplant is not an option here because of a lot of reasons in our country. So it is just supportive care that the patient is on oxygen and some low dose steroid that was started for this patient.
Thank you so much, Vijay. That's super interesting. Leon has mentioned that this has a strong family component. Was there any information that you could gather concerning the family history?
Somehow we could not get any history of any liver or lung disease that anyone in the family had. So this was the index presentation that the patient had.
Thank you so much. Leon, what are you thinking?
I think your likely diagnosis makes a lot of sense, and it's what I was thinking. This is a phenomenal case, and a really interesting case where there's more than one thing going on. So you demonstrated with that arterial blood gas that the patient definitively has hepatopulmonary syndrome. But what's interesting is I doubt that it's this hepatopulmonary syndrome that's contributing to the majority of the patient's hypoxemia. As with any genetic disease, there's always an index case. There can be a de novo mutation. And the penetrance, my understanding, and I'm certainly not an expert on short telomere syndrome, but the penetrance of short telomere syndrome is incredibly variable, and the expressivity is variable. So it is very possible that he doesn't have a significant family history of this. There really, at this point, without the option for transplant, unfortunately, this will likely continue to progress. And I think oxygen supplementation for now and focusing on any sort of lifestyle modifications we can. And what I mean by that is energy conservation, things like that, palliative measures is going to be most important for the patient. It's a really unfortunate disease process.
Thank you, Leon. Vijay, would you like to share how the patient is doing now and how the prognosis is from now on, and maybe some of the things that you learned from this case and working with this patient?
So the only thing was, it was very interesting. This is the first time, although we have read it up, it was the first time I'm encountering something like this. So my major learning was to keep it very broad. And this case was particularly difficult because patient had multiple things that could be explaining as dyspnea. So that was somewhere where we had to say what is really causing us dyspnea. So once we had the final diagnosis, somehow the patient, it was hard to break this news to him. After that, somehow he did not take it that well. So he's just taking supplemental oxygen. He just comes for a visit once a month. So we have just kept him on regular follow-up. So I think major learning for me here was patient will have so we missed the graying of hair that maybe if we picked up early, we could have picked it up early and we could have a comprehensive diagnosis at the end. But sadly, with most of these ILDs, without transplant, there's not much we can do for them. So this is one thing that is not there in our country as of now. So I'm just looking forward that someday we can do much more better treatments for these people.
Vijay, can I ask first of all, thank you for your care of this patient. This must have been very, very difficult. I wanted to ask, was he offered antifibrotic therapy
Yeah,
as an
we
outpatient?
just started him on both steroid and
Okay.
antifibrotic,
Yeah.
just for whatever benefit it does.
Yeah.
Thank you, Vijay, for bringing this case here and for sharing your thoughts. I think it's a fantastic case, and we started from a very common chief complaint and ended up with a very rare and difficult diagnosis, I believe. But I think, Leon, it was such a fantastic discussion, and I really learned a lot, and I just really want to thank you for being here, and I hope it's not the first time and not the last time that you'll be here. It was a ton of fun for me, and I think before we close the session, I would be super curious if there are like 2 or 3 points that you would like everybody to take away from today's discussion and how we approach pulmonary patients.
Thank you so much for inviting me to be here. I had a lot of fun. I thought this was great. I learned a lot from this case as well as I was processing things. A couple take-home points. I think ambulatory saturations testing is so helpful for a number of reasons. We do them often in clinic, but you can just as easily do them in the emergency room or in an inpatient setting. And outside of telling you this patient needs oxygen, which is also very helpful, it can really narrow your differential as it did in this case. That dramatic of a desaturation can really only be caused by a few different types of disease processes. So that immediately helped narrow the differential. Keeping a broad differential in pulmonary is often very, very important. And I would really caution against premature closure. Imagine if you had not gotten the chest CT and had just done the bubble study for whatever reason. You may have closed on hepatopulmonary syndrome as the sole etiology of this patient's dyspnea. But you have to remember that people can have, in fact, sick people often have more than one thing going on at a time, and just not anchoring, oftentimes in pulmonary, it's more of a hiccum dictum rather than the other one. So just remember that you can have multiple things going on at once, and keeping a broad differential is really helpful. Thank you. Occam's razor.
Yeah, thank you, Leon. Thank you, VJ, so much for a fantastic hour, and thank you to Ethan and Parisa for scribing and doing teaching points and organizing the whiteboard so well. Yeah, thank you all for being here today, and I hope to see you all next week or tomorrow. Please enjoy the rest of your day. Bye. See you all.